All right. Well, hi, everybody. My name's Dan Getz. I'm the Chief Medical Officer for Providence Health Care acute divisions, so over Sacred Heart Medical Center as well as Holy Family Hospital, serving as the Chief Medical Officer. We've invited everybody here today to hopefully give a glimpse into the preparedness that we've gone through for the COVID-19 response. This is the culmination of actually months of planning and learning a lot of lessons from our partners on the west side, and ensuring that we have all the products, supplies, as well as the specialized care providers that we need to care for people when they come in that time of need should they be dealing with COVID-19. A couple interesting points, I think, about COVID-19 to recall. About 20% of patients with COVID-19 may require hospitalization, and about 5% of them may require the intensive care unit. We have the ability right now to staff approximately 80 intensive care unit beds if we need to. We've really ramped down our outpatient surgeries, our elective surgeries, really anything that we didn't deem as a critical need, so that we have capacity care for people in our community. In the early planning, we focused on space and capacity, and we have plenty of space and capacity right now. Also, I think it's important to note that we really want people that do have emergent conditions that aren't related to COVID-19 to please come to the hospital. Throughout the community, we've heard reports of people delaying emergent care because they're worried they're going to get COVID-19 at an area hospital. We've really focused and planned, and you're safe to come. So, and actually, delaying emergent care is probably a bigger community threat right now in certain cases than actually getting the disease. And then I think the rest is questions.
So this bed right here, is this just the normal bed when a person is admitted at birth?
Well, so this is a standard hospital bed. If somebody came in and they didn't have aggressive respiratory needs, so they weren't requiring intubation and being put on a ventilator, they just required normal admission convalescent care, so IV fluids and supplemental oxygen. This would be pretty similar to the setup that they would have in the inpatient setting.
So when does that change? When you decide a patient needs to be put in the ICU, what changes for them as far as what they're being treated with?
Yeah, so when you go into an ICU, usually you have much more labor-intensive care. So you have usually your own nurse, you have your own room, you have access to all the higher-end supplies that you require to care for somebody with more aggressive respiratory needs. You have closer access to medications. Usually we see as patients start to require beyond 6 liters of oxygen by nasal cannula, usually they're at higher risk for having respiratory failure. So we like to watch them more closely in our intensive care unit.
And does each ICU patient go onto a ventilator, or is it kind of different?
No, ventilators are a small piece of our ICU patients. It can depend on lots of different things. And we have patients that just need help with their blood pressure. So maybe they need use of medications that are administered through an IV that we need to keep close track on. So they could go in an ICU for that. Sometimes they just need more nursing support. So they need close monitoring. Sometimes that would qualify for the ICU. All of our intubated patients where we're supporting their ability to breathe with a ventilator machine that does that would go into an intensive care unit.
When you talked about months of planning, when this started ramping up and we got those 4 initial patients here at Sacred Heart, they went to that special pathogens unit. What's changed from when they first got here to now as you see more and more patients with this? Well, is that unit still being used?
Well, so what we've done is we've really expanded our hospital to be able to have the capacity to care for multiple patients with COVID-19 if we needed to. I think at that time when we first received those batch of 4 patients to our special pathogens unit, we weren't quite understanding of the scope of the spread of this disease. So using that, we use very similar policies to what we did when we cared for those patients, focusing on safety, ensuring that we're not transmitting this disease to other patients. And so all of those policies that Krista will demonstrate, we follow very, very closely. It's pretty rigid standard operating procedure to make sure that you're ensuring the safety of both your patients as well as your staff.
And wanting people to not put off emergency situations because they heard, speaking to that, is the capacity of the hospital handling all of this okay? Like, we're not running into any issues there?
No capacity. We have no capacity issues. We have lots of capacity care for people that are sick, and that's my concern right now is that people are scared. And if you're having a heart attack, the last thing I want you to do is wait at home. We want you to call 911 and come and get the care. If you fall and you break your hip, we don't want you to suffer at home before you finally decide to come in and get seen. We have the capacity to take care of those patients in our community as well as the patients that are presenting with COVID. And right now we're by no means overwhelmed with either type of patients. We have the capacity to provide pretty expert care. We have staff that are highly trained in delivering care to both patient populations. And again, we're dividing those populations. So if you come in to get care for a heart attack, please don't worry that you're going to be next to a patient with COVID-19 in the hospital.
We've seen extra precautions taken just with us being here with masks and hand sanitizer, and we're going to clean off those microphones when we switch speakers. Is that just the standard practice throughout the hospital now, no matter what population you're in?
Yeah, we're kind of cleaning everything all the time. I think you're seeing that all over the place. High-touch surfaces we're trying to disinfect regularly. That's the problem with COVID-19 is it's pretty easy to spread. And we look at what's called an R0 value, which is the ease of spread. And I think the last thing that I read showed that approximately one patient will give it to 2.2 others. And a lot of that has to do with droplet spread, where you kind of aerosolize, where you kind of spew out these droplets with virus particles in it. But also there is that if you're touching something that's infected, you need to take precautions, and I think that's the benefit of community masking is you're less likely to touch your face with a mask on. Also, if you have a cough, you're less likely to spread that to others. And I think it's almost a totem of awareness just to recall that you have to do these things. Good hand hygiene, not touching your face.
Dr. Getz, you mentioned that you have the capacity to staff 80 ICU beds, but that's not total beds for potential COVID-19 patients, right? I don't know if you have numbers or if that number's fluid on other beds, but if you could elaborate on that.
Yeah, so ICU beds are special beds. Those are kind of one-on-one nursing, very aggressive care. In the hospital, we have over 600 beds if we need that. And so we have the ability to expand our beds, even ICU capacity. If we had an influx of critically ill patients, we can adapt to that. And part of the things that we did early on was really developing a very good model for the ability to staff from both a physician and advanced practice standpoint as well as nursing standpoint. So we can even expand beyond that if need be. But the hospital, it's a giant hospital. We have a lot of beds to take care of patients.
And the special pathogens unit, I know I was told that you guys are not using that right now because these patients don't require the extreme level of care that unit needs. Can you kind of expand on why that is?
Let's hold that.
Yeah, I'll hold that for Krista Argentiona, who she helped invent that unit. So.
One more question on people coming into the ER for other emergent care. When you do have patients that are presenting COVID-19 symptoms, can you explain sort of where they're being, funneled to or directionally going versus the regular ER to sort of ease people's fears on that?
Yeah, that's a great question. So we have a lot of different pathways in the community. Right now, we're encouraging at least use of the Fairgrounds tent facility for people to be screened that are having mild symptoms. Anybody that's having symptoms that they feel they need to be seen by a doctor, so you're having chest pain, you're shortness of breath, we want you to come and get seen at our emergency department. And we have a separate waiting room at our Providence emergency departments for patients with respiratory symptoms. And then we also have divided our emergency department, which is a very large emergency department, into separate areas that care for patients with fever or respiratory complaints. I think the important piece to note is a lot of patients can come in with symptoms that aren't necessarily cough. We're even seeing now diarrhea can be a symptom of COVID-19 patients. Loss of taste and smell is one that's starting to see in the press now too. So we're really taking all that into account, screening patients appropriately, and then placing them into an area where we can provide a rapid assessment and ensure that we're not infecting others. So lots of measures throughout the hospital, emergency departments. We have an urgent care that's operating as a fever clinic. So we're trying to send patients with fever or symptoms concerning for COVID and that need screening to those urgent cares so that we're really trying to isolate that population away from people that have kind of normal illness that we deal with on a day-to-day basis.
Thank you.
Thanks.
And I assume the dynamic has really changed for all the employees here. If you were focusing on one medical field at one point, it's now changed, or how has that kind of changed for you?
I think the big change for us is we've really tried to prioritize caring for patients in the community that would present with COVID-19. So, I think that's been frustrating for patients who have had elective surgery scheduled, and now we've had to postpone those. And we're definitely going to get to those patients when it's safe to do so and we feel like we have a handle on this pandemic. But a lot of that was done to conserve our resources of PPE, as well as potentially avoid patients that come in and now they've had a big surgery and need to convalesce and could potentially get COVID-19. That's been a hard thing to adapt. But I think think the biggest thing is, people are doing really heroic things now as part of their day-to-day workforce. Our labor pool as far as transporters, environmental services, our food workers, across the whole spectrum of healthcare, these patients are putting themselves, or these caregivers are putting themselves at potential risk to deliver this service. So I think that's provoking anxiety. We're doing everything that we can with our available resources and supplies to keep our personnel safe. And that's obviously our big priority, but you're operating in a scary environment. We haven't seen this before, we haven't dealt with this before, and I think that's, no matter how much we try and reassure folks, there's always that layer of fear. And you see that even in the community, people that don't work in healthcare, we're terrified about all these types of things, and I think it's that fear of unknown.
Is there a specific number of ventilators that Providence Health has?
We keep close track of our ventilators, and one of the things that we did early on was really trying to make certain that we have an appropriate number of ventilators to deal with patients with respiratory failure in our community, and that's been a regional collaborative approach. We work closely with multi-care as well as other resources in the community to make sure that we have an appropriate number of ventilators. I'm very positive that we have, feel very strongly that with what we have now, we can deal absolutely with the worst case scenario in our community, again, relying on the community resources that we have.
What about your supplies of PPE? Do you feel like you have adequate supplies?
I feel like it's a moving target, and so you use these supplies on a daily basis. We're trying to adjust based on the volume of patients that come in. So I feel that the way we're stewarding these resources, that we have them allocated in the right way, that we can meter them out and hopefully not run into a shortage. I mean, the last thing that we want to get into is where you have caregivers and staff that don't have appropriate PPE to care for high-risk patients, and I feel that we're not there, but we're working very closely with supply chain, regional partners. We're working with the health district to make sure that we have an ongoing supply of that.
A message to the community who might be worried about this. Do you feel optimistic of where we're at right now?
I feel very optimistic, but I'm always optimistic. But I think one thing that they need to realize, and we have a phenomenal community of healthcare providers and caregivers, and they've all stepped up to really serve in this time of need. And just realize that they have people that are highly trained and specialized in delivering care to the sickest patients in our community, and we have, at this point, the resources to do so. So, let us worry about those things, those logistics pieces, and making sure that we have the staff and the specialized care is there, and we feel confident we have that right now. That's the thing I think that's hardest for me right now, is just the amount of worry across all levels in society. It's just through the roof, and I think, as a society, we worry excessively and for good reason. But there's been a lot of planning and a lot of discussion with experts across the country on how we're going to approach this issue, and I'm encouraged with what we're seeing.
All right. Thank you, Dr. Getz.
Thank you.
Let's switch it up.